Hi guys, good evening, good evening, good evening. Welcome back to another series of our BLS. We're continuing on the small intestine. Hi guys, good evening. Congratulations to all the NEET PG aspirants who got their ranks well. I've got a couple of DMs, I've been responding to them. Congratulations to every single one of you. Now it's the time to think about what residency you're gonna choose. If you need any help, please reach out. Those who could not cross as because of various reasons will again regroup. We'll try to understand and re-strategize. So don't worry about it. It's not the end of the road. Okay. Now, having said that, again, congratulations to every single NEET PG aspirant who scored it well today. Now, we will continue with what we were doing yesterday and what we do the best, and that is to cover our topics. So we start with small intestine. The reason I spoke about the embryology yesterday because I wanted you to understand a very, very important topic which is called as the intestinal malrotation. So today's opening topic would be your intestinal malrotation. Now, this is something that you will see exclusively when you go to a pediatric surgery wards or you have a pediatric surgery rotation, right? Hi guys, good evening, good evening, good evening. Hi Rishabh, good evening. Right. So again, intestinal malrotation is a topic that you all should understand. It's a very, very conceptual topic. Many a times you don't understand ki kahan se rotate ho raha hai, why is it rotating, why it is not rotating, how it is rotating, and what is this malrotation, what is the problem that it brings in. We'll try to understand. Yesterday, if you remember, I told you the entire midgut ki jo complete story hai, right? We understood that the midgut's development, I'm going to concentrate on midgut because this is going to be developing in the midgut component resulting in midgut volvulus. So midgut ki jo complete story hai, that started from the 4th week of its embryonic development. I told you 5th week was its rapid growth phase. It goes into the umbilicus and 10th week is the return one. Okay. So by the end of the 10th week, the midgut is going to return back, right? Palash, sorry to hear that you couldn't get well in your NEET PG exam. INICET is there in November. We'll target that. So don't worry. Don't lose your heart. If you have anything which is you want to discuss it personally, you can DM me on the Telegram or as the Instagram. We'll connect there. So don't worry about it. Okay. So yesterday we spoke about it. The development is going to start at the 4th week. The rapid growth phase is going to be 5th week and return to the home is going to be on the 10th week, right? Now, I told you the midgut ka jo development hai, it is going to be extracoelomic, that is going to be through the umbilical ring, it goes out and starts to develop. Now, a very interesting thing that you need to understand, which we've been talking about yesterday also, let's say this is the coelomic cavity we're talking about, and this is the umbilical ring, or I can say the umbilical cord. I'm just going to keep it across here, right? I'm not worried about what happens in the rest of the embryonic component, but I do know that this is where you have the component that is going to be present. And we're saying, okay, we'll use a different color here. So we're saying that the development that is going to occur of the midgut is going to be extracoelomic, right? So this is what it is going to happen. Now, when you look at the extracoelomic ends, yesterday also we spoke about it that there are two ends which are going to be present. One is going to be the cranial or the caudal end. See, the cranial or the caudal end, cranial is towards the head, caudal is going to be towards the base of it. इतना सबको पता है, ठीक है? The blood supply is predominantly जो aorta से निकल के आएगा, that is going to be a superior mesenteric artery. So this is the axis of your superior mesenteric artery. So just for the sake of understanding, I'm just mentioning it here. That superior mesenteric artery is the axis, and then you have the midgut that is going to develop around the superior mesenteric artery as an axis. So what I'm going to do is I'm going to segregate this part of the midgut, which is before the blood vessel. We'll call this as the pre-arterial form or the pre-arterial bowel loop, or also simply called as the cranial bowel loop, right? This I would like to call it as the caudal end or post-arterial. We'll call this as the post-arterial arterial end of the bowel loop, which we'll call it as the caudal end. Okay. Everybody is clear until this? We have already discussed it. What is the pre-arterial and what is the post-arterial, which is the cranial or the caudal end. Okay. I am just going to take this into consideration and try to understand what is happening around that area, right? So what we have the axis, which is going to be your superior mesenteric artery, right? So this is your superior mesenteric artery as an axis, and you will see the bowel loop is going to develop around this component, and we'll name this as the pre and the post. We'll name this as the pre and the post component. Okay. So this end which is present, this is the pre-arterial, this is the post-arterial. Okay. Now it is very difficult for us to understand कि यार ये pre-arterial क्या है, post-arterial क्या है. The superior mesenteric artery will be supplying the blood to every single component, which is going to be developing from this particular form of the midgut. To make our life easier, I will say the pre-arterial form is the duodenojejunal junction. So I will call this as the duodenal end. Agreed? Okay. The post-arterial, we'll call this as a cecal end. Right? Now we have defined two ends of the bowel loop. एक आपका प्री आर्टीरियल हो गया, दूसरा आपका पोस्ट आर्टीरियल होगा. प्री आर्टीरियल को मैं डिओडिनल एंड बोल रहा हूं, पोस्ट आर्टीरियल को मैं सीकल एंड बोल रहा हूं. इफ यू हैव गॉन थ्रू आवर यस्टरडेस लेक्चर, आई हैव टोल्ड यू वेरी स्पेसिफिकली कि प्री आर्टीरियल और पोस्ट आर्टीरियल, दैट इज क्रेनियल और कॉर्डल एंड से क्या क्या बनता है. क्रेनियल एंड से बनेगा until the proximal end of your ileum, whereas the caudal end will form the rest of it until the transverse 2/3 of the colon. So the cecum belongs to this particular site. Okay. Now, as I told you that once the development is going to start, what is going to happen? There will be, once the development is complete, when the 10th week, when it is coming back, when the ghar wapasi returning is happening, there will be 3 right angular turns, 90 degrees, 90 degrees, 90. Actually, the last 180 occurs after it goes into the abdomen or it goes into the coelomic cavity back, but we'll say it's total as 270 degrees. So what is going to happen? We'll take the cross section, right? Now imagine if you're taking the cross section, I will call this as the superior mesenteric artery, right? This is your superior mesenteric artery. On this end, I would say this is the duodenal end. So this, the pre-ileal one. The post-ileal, we'll call this as the cecal end. Okay. इन दोनों के बीच में you have the bowel loop that is getting developed. ठीक है, nothing spectacular about it. And we're saying this is the arterial end. यहां तक सबको क्लियर है? ठीक है. So I've just created clear. Until this point, everybody is clear कि ये orientation है हमारी superior mesenteric artery के duodenal end और cecal end की, right? Now the first rotation that is going to occur is going to be the anti-clockwise direction. So this is the first rotation. This is going to be in anti-clockwise direction. This is your anti-clockwise direction, and this is going to be on 90 degrees. Okay? Now you need to understand this way. Now you take this as the duodenal end, this as the cecal end, this is your superior mesenteric artery. The first right angle will be like this. ठीक है, the first right angle in an anti-clockwise direction is going to be in this particular direction. ठीक है, तो ऐसे वाला था, ऐसे हो गया. ठीक है. Now once this 90-degree rotation has occurred, what is the end result that you're going to have after the end of the first rotation? After the end of the first rotation, you would see that the superior mesenteric artery. Now this is the superior mesenteric artery. Now everything, all three is going to be in the same line. Superior mesenteric artery is here. This is your superior mesenteric artery. This is your duodenal end. This is cecal end. It is rotating. Now all these three, that is your superior mesenteric artery, duodenal, cecum, all of them are becoming in one straight line. No, it is like this. First 90, it has become like this, right? So all three of them are going to align. Like just say it is going to be like an eclipse. So this is your duodenal end. This happens to be your cecal end, right? This is your duodenal end. This is your cecal end. All three of them have now aligned in a single line because the first 90-degree rotation, right? This is the first 90-degree rotation, right? This happens to be your first 90-degree rotation. Again, the axis is going to be superior mesenteric artery. Okay? So this is after, this is the orientation after the first 90-degree rotation. Correct? Nothing much has changed. Okay? Nothing much has changed. They all are in the same direction. Right? Now, bowel says I have to go a little bit more. So again, there will be another 90 degrees. Now, it was the superior mesenteric artery. This is the cecum. This is the duodenum. This is now it has come. Right? If there's another 90, it will become like this. There will be twist that is going to occur. And now you see cecum has come on top. Our thumb was cecum and this is duodenum. Initially, cecum is here. First 90, second 90. After the end of the second 90, there is 180 degrees. Cecum has now gone on to the top. So there is role reversal that is going to occur. So again, we'll have the same orientation. I'm saying the superior mesenteric artery remains here. Once there is second 90-degree rotation. So this happens to be the second 90-degree rotation. There is this second 90-degree rotation. In a second 90-degree rotation, you will now notice that the cecum has now become on top. The duodenum has now become on bottom. And there is role reversal. That means there'll be twist. See, it is like this. It has become like this and like this. So you see the cecum is coming on top. Okay? The cecum is going to come on top. So this is going to become like this, right? So there is twisting of the bowel loops also, but the axis still remains the same. That is your superior mesenteric artery. So this is after 180 degrees. So this is after 2 turns. That is going to be 180 degrees anti-clockwise. This is after 180 degrees anti-clockwise. Okay. Is everybody clear until this point? Did you all get it? Clear? Okay. So this initially started off with a very simple rotation. There is 190, there's alignment, then there is 180 पे पूरा alignment हो गया, and then it goes in a reversal. अब cecum ऊपर आ गया, duodenum is going to be on bottom after 180 degree turns. Now add another 90 degree to it. ठीक है? Because after 180, no, the total rotation is 270. So what is going to happen after 270 rotation? This happens to be your superior mesenteric artery. Now the cecum, after another 90 degree turn, they will align. So cecum is becoming on top. Duodenum is going to come on bottom. They all are going to align into the same line. Okay? After another 90 degrees, they all align into the same line. The role reversal was there. This continued to be there. The axis was your superior mesenteric artery. So the axis still remained at the superior mesenteric artery, right? So this is going to be the cecal end. This happens to be the duodenal end. This happens to be your superior mesenteric artery. This happens to be your superior mesenteric artery. Clear? Okay. So this is after 270 degrees anti-clockwise rotation. Anti-clockwise को आप counter clockwise भी बोल सकते हो, but this is what the whole objective is. Clear? ठीक है? तो ये मोटा मोटा ऐसा सीकम ऊपर हो गया, डियोडेनम नीचे हो गया. तो एंड रिजल्ट क्या होगा? एंड रिजल्ट आपका ये होगा कि यू विल नोटिस दैट दिस इज द इसोफेगस, दिस हैपेंस टू बी द स्टमक, दिस हैपेंस टू बी द डियोडेनम. अब इसके बाद से द अदर एंड ऑफ द डियोडेनम विल स्टार्ट, दैट इज द थर्ड एंड द फोर्थ पार्ट ऑफ द डियोडेनम. द जेजुनम विल कंटिन्यू टू हैपन. ठीक है, तो यहां तक आपका डियोडेनो जेजुनल सेगमेंट हो गया. Right now, this DJ segment is now completely formed, and this is how the bowel loop is going to be present. Then you will see the post arterial one, which is going to be cecal end, will start to form. The terminal ileum is going to be here. They will form the appendix. They will form the cecum. and then they'll form the ascending colon and the 2/3 of the transverse colon, which appears to be like this. ठीक है, तो ये आपका end result हो गया, right? Now the beauty of this is because again the whole component is supplied by your superior mesenteric artery, it remains in the same component. ठीक है, तो आपका जो superior mesenteric artery का flow है, this is how the aorta is going to flow, right? This is where the aorta is going all across here. ये आपका aorta है, right? Now you will see that the superior mesenteric artery is going to arise through this part, which is going to be above the duodenum. It overshoots the duodenum and goes like this. ठीक है, ये आपका superior mesenteric artery है. Now, what is interesting to know that superior mesenteric artery goes above the duodenum and then you have the right and the left side. ठीक है, ये आपका right side हो गया, ये आपका left side हो गया. The small bowel will always lie left to that of the superior mesenteric artery and cecum will always lie right to that of superior mesenteric artery. Eventually, what is going to happen as the development is complete, because of its rotational status and the weight, cecum is now going to come downwards. ठीक है, तो धीरे 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 cecum नीचे आ जाएगा and the whole alignment is going to fix by itself. ठीक है, once the alignment fixes, the end result that you will see, this happens to be your esophagus, this happens to be your stomach, this is the proximal end of the duodenum. From here you will see there's a distal end of the duodenum and the jejunal junction, and from here you will form the jejino-ileal conduits, and this is now going to go with your terminal ileum, appendix, cecum, and then you will have the ascending colon which is formed here. From here you will have the transverse 2/3 of the colon, then you have the distal part of the transverse colon, the descending colon, the rectosigmoid, and the anal canal. So rest of the part is going to be here, right? Another important thing that you will notice that the superior mesenteric artery, that is, this is the aorta that we've been telling across. There's certain things which acts as a pointer for us. So this is going to be the aortic loop that is present. This is the superior mesenteric artery, right? This is the superior mesenteric artery which supplies the entire midgut. Now, what you have to understand in a very precise manner, that when you see this area, that is your duodenojejunal or entire component of the small bowel, you need to understand that this usually remains. Now, this is the right side of the superior mesenteric artery, this is the left of the superior mesenteric artery. You will notice that the small bowel stands, the small bowel, which is with respect to your, we're talking about the superior mesenteric artery's orientation. With respect to your superior mesenteric artery, I now know that the small bowel, specifically when you talk about the duodenojejunal junction, stays left, and on the right side you have the cecum. So cecum always stays right of the superior mesenteric artery. ठीक है, so ये आपका orientation है. So if I take this as the referral point, ठीक है, if I take this superior mesenteric artery as a referral point, from this point onwards, right, from this point onwards, whatever I've told you, cecum stays here, small bowel stays here. Clear? ये आपका basic orientation है with respect to bowels rotation. Is everybody clear on this? A quick feedback, please. See, these are the concepts which nobody teaches you, but they are very, very essential and very, very important. There are these bands which are present. Once the large intestine goes, it fixes to the retroperitoneal component. Cecum, specifically, when I talk about it, when I go and talk about the cecum, there are these bands which you will be seeing attached to the cecal end. No matter whatever is the position of the cecum, you will see in both sides of the cecum, you will have these bands which are positioned. There are these bands which are positioned on the either end of the cecum. These bands which are present on the either end of the cecum, these are what we call it as the LADS band. These are the normal retroperitoneal attachments. These are the retroperitoneal attachment of सीकम. सीकम की चाहे कोई भी पोजीशन हो, ये लैड बैंड हमेशा बनेगा. ठीक है. It attaches sometimes to the subhepatic space, like it's in the same context as your ligament of Tate's, but then these bands are your cecal attachments. इतना याद रख लो, lad bands are cecal attachment. इतना clear है सबके लिए? Is everybody clear until this point? ठीक है. So this is with respect to the basic orientation of the rotation. We'll go a quick component about it. So as I told you, to understand rotation, you need to understand that midgut has a point or pivot point through which it is going to rotate. The pivot point is going to be a superior mesenteric artery, which is attaching here. Now the midgut which is present is divided into the cranial end, which is on the head end, and the caudal end, which is on the toe end. The cranial end is also called as pre-ilial before the artery, and this the thumb, which is the caudal end, or also called as the cecal end, is the post-ilial. तो अब मेरे पास दो components है. ये superior mesenteric artery को मैंने axis बना लिया. ठीक है. I've made superior mesenteric artery as axis. Then I have this, which is the pre-ilial, and this which is post-ilial. Pre-ilial को मैं duodenal end बोल रहा हूँ. Post-ilial को मैं cecal end बोल रहा हूँ. इतना clear है? ठीक है. Now, what is going to happen is the rotation is going to take place in an anti-clockwise direction, total of 270 degrees. तो पहला rotation जो वो 90 degrees हुआ ऐसे. ठीक है. When it becomes all three structures are in the same line, the second 90 become like this, so 180. अब now when the second 90 occurred, you can see here, initially duodenum was on top, or the duodenal end was on top. After 180 it will be total reversal. ठीक है. तो duodenal end नीचे आ जाएगा, cecal end ऊपर हो जाएगा. ठीक है. और एक और 90 degrees के बाद all three of them will become the same line. Now what has happened is cecum has gone on to top. Now you can see here, that is why you can see in this diagram cecum is on the right upper part of the abdomen. वो ऊपर कैसे आया? It is because of that rotation, right? So once that rotation has occurred, and eventually when 270 degrees completes, you can see that is why, you know, you will always find that the transverse colon, if you see here, this happens to be your ascending colon. Agar if I have to give you a more precise objective, you will see, you can also ask, no, why is the transverse colon going over the duodenum? Why is not duodenum going over the transverse colon? The answer is right in front of you, because of that rotation. Because that rotation, you can see here, ये जो twist हो रहा है ना, ये cecum को उसके ऊपर लाके छोड़ रहा है. So that is occurring because of this particular reason. Is everybody clear with this? ठीक है. It's a very, very basic concept, but this is what you need to understand about your rotations. Now, if you have understood rotations, अब इसमें लोचा होगा तो क्या प्रॉब्लम होगा? उस प्रॉब्लम को हम बोलते हैं malrotation. ठीक है. Now, what are the different types of malrotations? What can be the problem? Let's try to understand. तो इस पूरे सिनारियो में, in the entire scenario, if things does not go according to your plan, they will land up into problem, and that problem is what we call it as malrotation. Now that problem is what we call it as malrotation. बड़ा simple सा concept है. ठीक है. अब malrotations कितने varieties के होते, कितने type के होते? The first variety is going to be complete non-rotation. It is going to be a complete non-rotation. That means the midgut that is developed, after developing, it did not rotate that anti-clockwise direction, और वो पूरा का पूरा वैसे ही आ गया. ठीक है. This does not occur. तो ये पूरा पूरा ऐसे अंदर वापस चला गया, right? So this, all this nonsense that we are talking about now, body says I don't want it, get lost, देखा जाएगा बाद में जो होगा, चलते हैं वापस. ठीक है. This is called as complete non-rotation. Now as there are two ends of the rotation, one is a duodenal end, another one is cecal end. The second possibility is if there is non-rotation, if there is non-rotation of the duodenojejunal junction with normal rotation, of cecal end, ये एक possible है. ठीक है. So this is also one type of malrotation. Another possibility is a converse of this. ठीक है. When I say converse of this, there is a normal rotation. There's a normal DJ rotation, that is duodenal rotation, with non-rotation of the cecal end. ठीक है. तो अब imagine that this is fixed only cecum, this duodenum stays here, cecum is only rotating, or the cecum is fixed only duodenum is rotating, right? Now these are two varieties of the non-rotation that you can have. One where you have non-rotation of the duodenojejunal junction, non-rotation of the duodenojejunal junction with normal rotation of the cecal end, or on the other hand where you have the normal rotation of the DJ end but non-rotation of the cecal end. और इससे worse क्या हो सकता है? What else can go wrong? जैसे what else can go wrong? There'll be reverse rotation, उल्टा घूम रहा. There could be reverse rotation. So rather than having a anti-clockwise rotation, here you have clockwise rotation. Now all these will create some sort of problem, and it is my job to explain you what are the problems and how will they present to you, what is the possibility that you're looking at, and what all can go wrong, right? So these are the various components that you have, right? So there are four possibilities in the malrotation. Either there will be a complete non-rotation, or there will be non-rotation where you have the DJ end is not rotating but the cecal end is rotating, or the DJ end rotates but the cecal end is not rotating, or there is a reverse that is going to be clockwise rotation. Reverse rotation is basically a clockwise rotation. Now when you look at this, the overall most common type of malrotation, the most common type of malrotation, the most common type of overall malrotation is a complete non-rotation. It is your complete non-rotation. Okay? So we'll try to understand each individual component and see what can go wrong, where can it go wrong, and we'll try to emphasize on the same component, right? So I'll take up the first topic or the first type of the malrotation, that is going to be your complete non-rotation. So in a complete non-rotation, what can go wrong? That means the entire duodenal end is on top, cecal end is on bottom, and they both went together, right? So when they both go together, what picture will they paint to you? So this is going to be the esophagus, this happens to be the stomach, this is the proximal end of the duodenum. Now because there's no rotation, it will not go to the left side, it will lie on its own segment. So this is the small bowel which is present. So this is the entire proximal part, and then you will see the distal end which is present here will rotate, will continue to form here. This is the cecal end, and you will see this is the colon, and this is how the colonic end is formed. So if there is no rotation, this is how the bowel loops will look like, right? The problem is you can see the entire small bowel. If I take the axis, if I divide the entire component as this, now you can see the entire small bowel is on, this is on the right side, this is on the left side, right? So you will see the entire small bowel stayed on the right side, the entire large bowel stayed on the left side. Problem is not that. The problem is, again, they have the vascular axis, which is a superior mesenteric artery. So you see the aorta, which is present here, continues to have the superior mesenteric artery axis, which is here. Now it is like a pedicled component which is present here. Obviously the blood supply to the cecum will also be here, which is going to come from your superior mesenteric artery, right? Superior mesenteric artery supplies to the transverse 2/3 of your colon. Okay, that is until the entire component. Now when you look at this entire segmental problem, there are two things that are going to exist here. The problem number one, you can see this end of the bowel loop. I will just mark it down. This end of the bowel loop is hanging from a small pedicle, and it is long, so it is easy to rotate. Now if this rotates, this rotation is what we call it as midgut volvulus, right? Volvulus is to rotate a bowel loop around its own axis. So the first problem is there is increased risk for midgut volvulus. And remember, the midgut volvulus is not a small thing. Midgut volvulus can cause severe ischemia, and that can result in loss of bowel. Now remember, around 18% of your total short bowel syndrome occurs because of midgut volvulus. Volvulus मतलब ये अपने आप rotate हो जाएगा. अब rotate हो गया तो vascularity to this end of the bowel, if it rotates, no, the vascularity to this bowel loop will be lost. And if it is not operated on time, then my friend, I'm sorry, you have to resect this end of the bowel loop, right? So this is what the whole problem lies in your complete non-rotation. Now in complete non-rotation, again you have the latch band which is present here. The bands which are present on the cecum will attach to the peritoneal reflection, which is going to override this way. So these are your lat band which is continue to be present here, right? Just for the sake of understanding, I'm just giving you a cross here. Now, how do you know it's a complete non-rotation? For a complete non-rotation, I will look at the superior mesenteric artery. Now, what was the normal orientation? The small bowel should have been on the left side and the cecum should have been on the right side. But here, with respect to superior mesenteric artery, you will see the small bowel lies onto the right side. It lies onto the right side, and whereas cecum lies onto the left side. This itself is the most important criteria to tell you that the patient is having complete non-rotation. Or complete non-rotation wale patients have a very high risk. They have a very high risk of developing. your midgut volvulus. That is your first type of your malrotation. Okay? Now, the second form of the malrotation that we had, was non-rotation of DJ, right? So the second form of malrotation that we had, it was non-rotation. It was the non-rotation of duodenojejunal junction with normal rotation. Of cecal end. Now, I know it is very difficult for you to picture how this is going to happen. So I'll make it absolutely simple for you. Okay? To understand this, now what we are going to do is, we will emphasize the same bowel loops that we have. Okay? Now, I'm saying, let's consider this as your esophagus. This happens to be the stomach. And this is the proximal end of the duodenum, that is here. Now, there is a non-rotation of the duodenum. So, duodenum is not going to change its position, or duodenojejunal junction is not going to change its position. So, this is where the duodenum and the jejunum will continue to be present. Okay? So, this is how the bowel loops are floating across here. Now, what is going to happen? I told you there is a normal cecal rotation. So, cecum will come to its normal position. So, what is the normal position of the cecum? The normal position of the cecum is here. This is the appendix and this is the terminal ileum. So, this is going to be its normal position. So, obviously, this end of the bowel will go and attach to this end. So, this is how it looks like. Eventually, you will see that this is the component that you will see across here. Okay. So, cecum rotated normally. This went on. Or rather, I would say, transverse 2/3 of the colon tak apne aap chala gaya, and the distal end of the transverse colon and the descending colon is here. Just for the sake of understanding, I'm just making it. Okay. Now, what again, the latch band is here, so I'm like least bothered about the latch band, which is going to get attached here. Right. So, latch band is going to go on top of this bowel loop, especially onto the duodenum, and it is going to go and attach to the retroperitoneal surface. Okay, दोनों end पे है. The medial end of the latch band is going to go over the duodenum. ठीक है. तो यहाँ पे problem क्या है? The problem that you can see is the latch band is going on top of the duodenum, the proximal duodenum, that is third part of the duodenum, कि ऊपर से जा रहे हैं और वो duodenum को press कर देंगे. ठीक है. So in a non-rotation of the duodenojejunal junction, where see, normally हमारा जो DJ junction है ना, normally the DJ junction which is present should have been here, ठीक है, on the left top, but वो गया नहीं वहां पे. ठीक है. This did not happen. It stayed in its position. Now, because it stayed in its position, the latch band had gone on top of it. Now it is compressing the duodenum. So, इधर क्या होगा? in this particular scenario, you will notice that the Ladd's band compression, it will result in Ladd's band compression over distal duodenum. Over distal duodenum, and this will result in duodenal obstruction. So here the baby is going to present to you with duodenal obstruction. Clear? Everybody clear about the non-rotation of DJ with normal rotation of Cecal? Okay. Now if you understand the concept, it's very easy for us to snap. ठीक है, आराम से एक के बाद एक के बाद एक के बाद एक के बाद you can just have that component. ठीक है, चलो. So this is about your non-rotation of DJ with normal rotation of Cecal. थर्ड वाला देख लेते हैं, where you had a role reversal. Role reversal में क्या था? There was normal rotation. There was normal rotation. There's normal rotation of DJ with non-rotation. With non-rotation of Cecal end. With non-rotation of Cecal end. Okay? Again, nothing spectacular. Same thing. Little bit of interpretation has to be changed, but then you will get the basic objective. ठीक है, तो यहाँ पे क्या हो रहा है? Normal rotation of duodenojejunal junction हो रहा है. That means that DJ is going to go to the left side, but the cecum is not coming down to its your normal side. Cecum का normal क्या है? Right lower था. वो right lower में आएगा नहीं, वो वहीं ऊपर रह जाएगा. Right? So let's try to have the same objective that we try to learn. Esophagus is here, stomach is here. They are like cool. They have no problem. This is the proximal duodenum. This end is the distal duodenum with the jejunal component. So you see the bowel loops which are present here are in its normal component, but there is non-rotation of the cecum, right? Now, because the cecum is non-rotated, you will see the cecum lies on its basic position. So basic position is going to be your terminal ileum is going to be here. This is the appendix. This is the cecum. And you see the colon and the transverse colon is going to go across here, right? So this is the whole objective. Now, as you can see, it has now created that this end of the bowel loop. Just see this. I'll make it this way. You see that it has now created this end of a bowel loop, which is only hanging by its vascular stalk. So जो vascular stalk होगा वही इसको यहाँ पे जो supply कर रहा है, that is what it is hanging. It looks almost like complete non-rotation, if you remember. Now, as I told you, in complete non-rotation में भी क्या problem? Because it is hanging like this. वो ऐसे hang कर, it is easy to twist around. This can also easily twist around. Now, as this can also easily twist around, there is increased risk. There is an increased risk for midgut volvulus. So altogether, there are two components. Altogether, there are two components which have got increased risk for midgut volvulus. They've got an increased risk for midgut volvulus, and you will see that the Ladd's band will still be present here. But this is now going to be more laxer. So it does not cause much of an issue here. Okay? So the Ladd's band, see, I cannot miss the factual component which exists. तो ये तो रहेगा. ठीक है? So this is your Ladd's band which still exists. ठीक है? So this is the whole objective. So because it is there, again it can rotate around its axis and result in increased risk for midgut volvulus. Okay. Ladd's band is your cecal attachment to your retroperitoneum. So it's the junction between the intraperitoneal and retroperitoneal space, and these like a fibrous bands which are going to present, they attach to cecum. That's it. Clear? So this is with respect to your third component. And the last one that you have is your reverse rotation. The last one that we have is what we call it as the reverse rotation. So the fourth one that we have, we call it as the reverse rotation. Now, as I've told you before also, in a normal rotation, the duodenum will go under the transverse colon. Reverse rotation mein kya hoga? Duodenum will come on top of your transverse colon. So let's try to understand the same objective here. This happens to be the esophagus. This happens to be the stomach. And this is the duodenum that is present. Right. So this is the distal end of the duodenum. It continues across here. So I'm not going to change anything, just the reverse rotation. That means only the orientation of the bowels rotation is changing, and this is going to cause some problem. We'll try to understand. So we have the same terminal ileum, we have the cecum, and this time when it goes like this. Okay, so यहाँ पे transverse colon पीछे से जाएगा, right? So as you can see, this is your cecum which is present. This is your terminal ileum. There's an appendix which is present there. And this is the rotational status. Right. Now the duodenum is sitting on top of it. So obviously duodenum is going to compress the transverse colon. It will cause the obstruction, right? It is going to cause the obstruction. Now, another interesting thing that you will notice, that the superior mesenteric artery that is present, the superior mesenteric artery also goes on top. It also rides over. So if I have to give you the entire objective, let's make, okay. So if I say that this is the aorta, right, just for the sake of understanding, let's say this is the aorta from where it is passing. Okay. So this is the aortic loop that is present. Superior mesenteric artery goes above the duodenum, which is going to be like this. But in this case, what is happening? The superior mesenteric artery also goes on top of the transverse colon. So here the superior mesenteric artery is compressing the duodenum to compress kar hi raha hai. Duodenum is compressing the transverse colon, but the superior mesenteric artery that is present is also compressing the transverse colon. It is also compressing the transverse colon. Okay. Now another interesting thing that you will notice here, that as duodenum is moving on top, as reverse rotation में क्या होगा, duodenum ऊपर आ गया ना, तो अब ये duodenum जो है वो superior mesenteric artery के ऊपर आ जाएगा. In general, you will see that the superior mesenteric artery is going to go above, the superior mesenteric artery goes above the duodenum. Here it goes under the duodenum, but it goes over the transverse colon. That's the very, very important factual point. The reverse rotation में क्या problem है? Reverse rotation में, rather than problem, what are the important salient features? Number one, duodenum lies on top of transverse colon. That's the first thing. Second thing you will notice that the superior mesenteric artery, it lies on top of transverse colon, and duodenum, or I can say superior mesenteric artery, the superior mesenteric artery goes under the duodenum. It goes under the duodenum. These are the facts about your reverse rotation which nobody tells you. Clear? Okay. So these are all the important aspects about your malrotation. These are all the important aspects about your malrotation. Clear? Clear? Right. So if you've understood the whole concepts of malrotation, the four different types. One is a complete non-rotation. Another one is a non-rotation of DJ with a normal rotation of cecal end. On the third one, there's normal rotation of DJ with a non-rotation of cecal end. And the last one, there's a reverse rotation. Okay? Now, if you're clear with this, we'll talk about the clinical features of your midgut volvulus. We'll talk about the midgut volvulus. It's going to be a midgut volvulus. See, normally, no, malrotation will not present to you clinically. Once it goes into your midgut volvulus, it will present to you. It's going to present to you as the rotation, or it's going to present as clinically as a problem. Okay. Number one, the midgut volvulus is associated with two varieties. What are the two varieties? It is associated with complete non-rotation, which happens to be the overall most common cause. Second, where you have the normal TJ rotation with non-rotation of Cecal, with the non-rotation of the Cecal. See, so this is about your midgut volvulus. Now, in general, talk about the clinical presentation. 90% of the patients who are going to have midgut volvulus, they present within first year of life. Within first year of life. Even more precise data. Sorry guys. Even more precise data of this 90% we are talking about, more than 50%. That is around 50 to 75% of the patients, they present to you within first month of life. Within the first month of life. Within the first month of life, right? Now, how will they present to you? We talk about the volvulus. See, the volvulus, when it rotates, no, obviously the bowel loop is going to get twisted. So when I say there is volvulus, this in a non-rotation, you see, this is how the bowel loops were present, right? So this is the normal orientation of the bowel loop, and this had an axis which is your superior mesenteric artery axis. So this is the blood supply which was going into the bowel wall all through it, right? Now I said there is rotation, that is your volvulus has occurred. Once the volvulus occurs, how it is going to happen? Now once it happens, you will see the bowel is going to get twisted. This is how the bowel is going to get twisted. The volvulus is basically the bowel end, or the vowel is getting twisted, but more importantly, it is now going to compromise the blood supply to the distal end. Now, if there is compromise of the blood supply to distal end, this end of the bowel wall is going to become ischemic, and when they become ischemic, that is severe hypoxia, will result in bowel wall necrosis. As simple as that. It can result in perforation, it can result in bowel damage, and that will result in short bowel syndrome. That's the ultimate component that you will see, right? That is the ultimate component that you're going to see once the volvulus takes place, right? Once the volvulus takes place, this is what you will notice. Once the volvulus takes place, this is what you're going to notice, right? Right. So this is the overall orientation of your midgut volvulus. Now, how will they present to you? Now, if the baby lands up with midgut volvulus, right? Remember, more than 60% of these babies will present with bowel obstruction. Volvulus is basically obstruction only. So they will present to you with bilious vomiting. They'll present you with bilious vomiting. Now, bilious vomiting with lethargic baby. With lethargic baby is the telltale sign that the baby is having midgut volvulus. Okay. Now, what is going to happen is these volvulus, when they rotate, they can rotate partially or completely. Now, because of partial intermittent, that means on and off volvulus, what it is going to result? So, because this partial intermittent volvulus, it will cause obstruction of mesenteric vein. It will cause obstruction of the mesenteric vein, and this obstruction of the mesenteric vein will result in bowel wall congestion. it will result in bowel wall congestion. This will also cause obstruction of the lymphatic channels. Now, as it will cause obstruction of the lymphatic channels, it will result in protein loss. It will result in protein loss into gut lumen. And the same thing can result in your chylous ascites. So chyle in ascitic fluid can also be because of the same reason. And the last one, it can obliterate the mesenteric artery. It can obliterate the mesenteric artery. Obliteration of mesenteric artery will result in bowel wall ischemia. It will result in bowel wall ischemia, right? Now, if there is a bowel wall ischemia, how will the bowel wall ischemia present to you? So the bowel wall ischemia, will present to you with melena because of mucosal injury. It can also present to you with perforation peritonitis. It can also result in perforation peritonitis, right? So this is the end story that you will see in a patient of midgut volvulus, right? How would you like to investigate? In terms of investigation, various investigations have been listed. You can perform the ultrasound. In a midgut volvulus, you will see presence of the whirlpool sign. If I say what is the investigation of choice, it is going to be the upper GI contrast study. In a midgut volvulus, what is the sign that you will see? You will see presence of a bird beak appearance at the third part of the duodenum. Bird beak appearance at the D3, right? Now, once you have concluded that the patient is having a midgut volvulus, there is no point wasting time. So you will jump into surgery. Remember, the surgery of choice is what we call it as the LADS procedure. Now, what is this LADS procedure? What do we do in this LADS procedure? I'm going to give you a very precise one. Step number 1, do an exploratory laparotomy. Take the patient for exploratory laparotomy. When you open up the patient, you will see there is volvulus. So usko re-rotate it back, put it back to its normal side. So do a detorsion of volvulus. Once you have done the detorsion of the volvulus, third step, it is to examine the bowel loops. You have to examine the bowel loops. Now, once you examine the bowel loops, I can have 3 possible scenarios. I can have normal, I can have borderline ischemia, I can have borderline ischemia, or there is necrosis or the bowel wall gangrene. As I told you, 18% of short bowel syndrome. 18% of patients who have short bowel syndrome are due to mid-gut volvulus, right? So obviously you will excise the necrotic bowel and do an ileostomy. If there is a borderline ischemia, then you have to do a relook laparotomy. And this is your exam question, especially if you are writing your NEET SS, right? All your surgery residents, they'll ask you when should you ideally do a relook laparotomy here. it is 24 to 36 hours. It is not 48 hours. Okay, so make sure you are across here. Now, if it is normal, then you will take up the step number 4. In a normal patient, I will take the patient for step number 4. So I will do broadening. So the first thing I'll do is to divide the cecal base or divide the lads band first. I will divide the lads band so that the cecum is freed now. After dividing the lads band, I will do cecal base widening. I will do a cecal base widening, and that cecal base widening basically are opening up the entire mesenteric component. So cecal base widening will result in broadening of mesenteric base. It will result in broadening of mesenteric base. That will result in broadening of the mesenteric base. So you have now widely opened it up. Okay. Along with that, I will also do appendicectomy. So appendectomy should be performed. Why appendectomy is performed? Because the malrotation occurs in the two varieties where both varieties cecum is on the left upper quadrant, right? So here, because the cecum lies on left, tomorrow if the patient develops appendicitis, it was diagnostic delay because classical right iliac fossa pain nahi hoga, patient will have left upper quadrant pain. Okay? So to avoid that, you have to do appendicectomy also. So this entire procedure is what we call it as the LATS procedure. In the LATS procedure, we are doing an exploratory laparotomy, doing a detorsion. We'll examine the bowel wall loop. If it is normal, I'll divide the LATS band. I will broaden the cecal base, right, by dividing the mesenteric components. So when you divide the cecal base, the mesenteric base gets widened. Widening will actually give you more space and less context of torsion. Another thing is, especially for residents, there is no role of fixing the cecum and the small bowel to the abdominal wall. There's no role of doing that. Even by that fixing, the probability of recurrence is 10%. Without fixing is also 10%. So you don't need to do anything. Okay? Just leave it there across. And these are the steps to be followed in general. Right? So this was an elaborate discussion on your midgut volvulus or intestinal malrotation. Very, very important topic and a beautiful topic. If you don't understand the concept, you'll never be able to wrap your head around it. Ki ho kya raha hai, kyun ho raha hai, kaise ho raha hai. But if you understand every single point that we have discussed, I took a real nice time for you to explain this. Now, I don't want to over say this, but I'm telling you this is the best explanation on internet that you can find on your bowel rotations as well as your midgut volvulus and intestinal malrotation. Thank you so much for joining today as well. So we have completed another very, very important and beautiful topic of intestinal malrotations, continuing our series tomorrow evening. Tomorrow, as it's Wednesday, we all know it is going to be an MCQ day, but there'll be a bonus class also. There'll be one more hour of your BLS lecture also, right? But a complete non-rotation में everything goes back in its normal space. कुछ rotate होता ही नहीं, वैसे वापस चला गया. ठीक है? Widening of the cecal base is basically when you divide. No, I'll come back here. So what I do is here you can see there's a lads band here. So first thing I'll do is when I say divide the lads band, I'm going to divide this. This is the lads band. When I divide the lads band, you can see the cecum is going far away from here. Bowel is coming here. So this whole space gets widened. You can see this whole space gets widened. And this widening will cause, because if it's smaller, it's easy to twist. If it is wide, it cannot twist. So the widening has to be achieved. So lads band को divide करोगे, cecal attachments को release करोगे so that it remains widened. ठीक है? Yeah. So that's it and all for today with respect to intestinal malrotation. Thank you so much for joining. We will resume back tomorrow. Tomorrow there'll be an additional 1 hour of BLS class followed by MCQs. Stay tuned for that as well. Thank you so much for joining. Good night. Take care. Bye bye.